Welcome to The Explainer. Today, we're unpacking a massive hidden flaw in modern medicine. We live in this era of unbelievable medical breakthroughs, right? Genomics, precision medicine, AI-driven diagnostics, and yet, right at the foundation of all this progress, there is a gaping void. Today, we're diving straight into the heart of a January 2025 report by the HBA think tank and FemTechnology to uncover how overlooked women's health is actively impacting clinical practice. Let's get right to it. 51%. Over half the global population is currently being treated based on clinical protocols that are overwhelmingly male-centric. When we think of modern medicine, we just assume it's universal, right? That it's designed for the human body as a whole. But the data reveals that more often than not, it's actually been designed for the male body. So you have over half of the population navigating a healthcare system built on a foundation that simply doesn't fully account for their distinct biology. And look, this structural bias isn't just some academic talking point. It is a lived, daily reality for female patients. According to the UK Secretary of State for Health back in 2022, 84% of women in the UK report feeling dismissed by their healthcare providers, and nearly half of women in the US report similar negative interactions. When the medical protocols don't match the symptoms a patient is presenting with, the system often just defaults to dismissing the patient rather than questioning the protocol itself. The clinical cost of that dismissal, it is absolutely staggering. We aren't just talking about hurt feelings here. We are talking about a massive diagnostic delay gap. On average, across most disease categories, men are diagnosed a full 4 years earlier than women. 4 years. That is a massive window where diseases can quietly progress, where early interventions are totally missed, and where women are left spending 25% more of their lives in poor health compared to men. Okay, let's dive into this. Why exactly is this happening? Well, it stems from something we call the default male baseline. This is the historical, systemic practice of basing medical research, clinical trials, and treatment strategies predominantly on male biology. Because female bodies have different hormonal fluctuations, metabolic rates, and biological compositions, historically they were viewed as just too complex for standardized testing. So the male body became the universal standard. And female health needs, they were treated as deviations from that standard, rather than essential biological considerations. Now, this data void didn't just happen by accident. Back in 1977, the FDA issued a policy that actively banned women of childbearing potential from participating in early-stage phase 1 and 2 clinical trials. That policy lasted for over a decade and a half. It actually wasn't until the NIH Revitalization Act of 1993 that the inclusion of women in federally funded research was mandated. But of course, that left decades of missing data. And that brings us to 2025, today's reality gap. Even though women are included in trials now, the foundational data in those legacy medical protocols remains overwhelmingly male-centric. Section 1. The physician's capability gap. When we look at the front lines, doctors are genuinely struggling to deliver equitable care within this deeply flawed system. A recent report surveyed 200 physicians across really diverse global settings, from the US to Germany, Brazil, and Egypt. An overwhelming 80% of these doctors clearly observe sex differences in how diseases progress in their day-to-day practice. But here's the kicker. Less than 30% actually feel equipped with the resources or guidelines to address those differences. Furthermore, 47% actively acknowledge that systemic biases and unconscious stereotypes undermine the care their patients receive. So the clinicians see the problem, for sure, but they are lacking the data-backed tools to actually fix it. Section 2. Real-world clinical consequences. Cardiovascular disease is literally the leading killer of women worldwide. But while the quote-unquote classic heart attack symptoms are chest pain and tightness, normal female symptoms are actually nausea, fatigue, and shortness of breath. Often female symptoms are completely dismissed as atypical or misattributed to things like anxiety or acid reflux. But the absolutely crucial point here is that these are not anomalies. They are the norm for women. Yet 77% of cardiologists report significant challenges in adapting male-centric protocols to female patients, which leads to massive diagnostic delays and much worse outcomes for women facing heart disease. And this brilliantly illustrates the real danger in drug development. Take the cardiovascular drug Multaq, for example. Women generally face a 1.5 to 2 times higher risk of severe adverse drug reactions compared to men. Why? Well, mostly because they aren't adequately represented in the trials. In the pre-approval trials for Multaq, only 32% of participants were women, despite the fact that women naturally have longer QT intervals that make them far more vulnerable to arrhythmias. So what was the result? Once the drug hit the market, a staggering 66% of severe arrhythmia cases were women. A male-centric trial process led directly to a devastating real-world safety failure for female patients. We see similar, glaring oversights in neurology too. There are stroke risk amplifiers that are entirely specific to women. For instance, the postpartum period, especially those first 2 weeks after childbirth, actually triples a woman's stroke risk compared to non-pregnant women. Adverse pregnancy outcomes like preterm deliveries or recurrent miscarriages amplify that risk even further, and preeclampsia creates a 4 times higher risk of suffering a stroke. Yet, despite all of this, these uniquely female life events and massive hormonal shifts are frequently just overlooked in standard, generalized stroke risk assessments. Section 3. The trillion-dollar opportunity. Now, according to the McKinsey Health Institute, in 2024, closing this women's health gap could boost the global economy by an astounding $1 trillion annually. This is driven by reducing the time women spend in poor health, keeping them in the workforce longer, decreasing those incredibly expensive late-stage interventions, and just improving overall productivity. Solving this data void isn't just a moral imperative for equity. It is quite literally a trillion-dollar economic engine just waiting to be unlocked. And the demand for this change is truly global. While the exact hurdles might differ based on wealth or geography, the core problem is universal. In high-income Germany, 60% of cardiologists report frequent difficulties diagnosing female heart disease simply due to a lack of guidelines. Over in middle-income Brazil, 100% of surveyed cardiologists recognize that heart disease manifests differently in women, but they completely lack the protocols to address it. And in Egypt, 60% of oncologists report that current research has absolutely no tangible impact on their specific clinical approaches. The global medical community is literally crying out for sex-specific data. Section 4. Redefining healthcare for all. So, how do we fix this? The report outlines 4 foundational pillars to really integrate women-centric practices into modern healthcare. First, we must collect data. We need real-world data to establish actionable, sex-specific guidelines so doctors aren't just out there guessing. Second, we must redefine the baseline. We've got to move beyond bikini medicine, the kind that only looks at reproductive organs, and recognize that female biology impacts every single organ system, from the heart all the way to the brain. Third, centralize resources. Women's healthcare right now is incredibly fragmented. We need interconnected models that treat the whole patient. And fourth, incentivize change. We have to reward pharmaceutical and medtech companies that actually prioritize sex-specific innovations through things like faster approvals or extended patents. But the really crucial point here is that progress is already happening. Mount Sinai's Women's Heart and Vascular Center is specifically designed to screen and treat the unique cardiovascular profiles of women, recognizing risks like spontaneous coronary artery dissection. Then you have Stanford's Gendered Innovations Project, which is actively developing practical methods to integrate sex and gender analysis right into scientific research. And innovative platforms like Ori are centralizing care, providing actionable data to employers to reduce costs while delivering personalized health navigation for women. These models are proving that sex-specific care isn't just possible, it's highly effective. So I want to leave you with a provocative question. Who will rise to this challenge and reimagine healthcare for all? We've seen the data today. Treating the male body as the default has led to widespread misdiagnosis, immense suffering, and a massive loss of economic potential. But we also clearly see the solution. By studying the 51% of the population historically overlooked, we can unlock unprecedented medical breakthroughs that will transform care for absolutely everyone. The data is clear, the tools are emerging, and the opportunity is staggering. The time to act is right now. Thank you so much for joining me for this explainer. Keep questioning, keep learning, and I'll see you next time.